Good morning. First, before I start, I would like to thank the organizers for inviting me to this wonderful conference and location. So, I'd like to present a very innovative, groundbreaking intervention that I helped develop at a harm reduction program which I founded in New York. A little bit about me. I started my harm reduction work in 1990 as an AIDS activist doing illegal needle exchange. And shortly thereafter, in 1992, needle exchange became legal in New York City. And surprisingly, I risked imprisonment for distributing syringes to drug injectors when at that time the NGOs were preventing access to life-saving services for people who use drugs unless they committed to abstinence upon entry. And that was inhumane and criminal. So therefore, harm reduction programs started, and we started organizing substance users and injection drug users and providing low-threshold access to sterile syringes and a bridge to other services. So today, in the program that I was working at, excuse me, yeah. Yeah.
We need our magic.
Oh, sorry. Thank you. Okay. So here's a little overview of the intervention. So Positive Health Project happened to be one of the most comprehensive programs in New York. And we developed this intervention. It was uniquely designed to serve drug injectors who presented themselves while experiencing withdrawal when exchanging syringes. The intervention included buprenorphine induction, stabilization, medical care, HIV, Hep C testing, and referral to continued maintenance treatment. Oh, wrong way. There we go. Okay. The goals of the intervention were basically to prevent high-risk injection behaviors among drug injectors while experiencing withdrawal symptoms. We wanted to offer drug injectors a daily reprieve from injecting drugs, whereby providing an opportunity just to take a break and to use whatever resources they had for food, housing, or whatever. And also to provide a very informal, low-threshold access to drug treatment. So the setting was, as I said, in a harm reduction program, and we pioneered the one-stop harm reduction model. As a result of doing some of these public health groundbreaking work, working with my friend and colleague, Don Desjardins, we did a Hep B vaccination study, which actually was responsible for the implementation of hepatitis vaccines in needle exchange programs in New York and throughout the US. I helped develop new injection equipment to address hepatitis prevention, and we opened the first licensed medical and dental clinic in a needle exchange program in the US. And as a result of that, drug injectors came in, they were actually triaged as they would in a public health clinic. Upon enrollment, they had access to testing, vaccinations, and treatment on the spot. So, for a little bit about buprenorphine in the US. In 2002, the FDA approved this wonderful new medication, and it became available as prescription under the brand names of Subutex and Suboxone, and is commonly now in combination with naltrexone. And it's very low risk. Because of the ceiling effect, overdose is very unlikely to occur. To prescribe this medication, what was so wonderful about it is that physicians can become licensed or authorized by the government to prescribe this in their office. and treat addiction as any other illness or disease. Because of this, I decided to take advantage of this opportunity because we had a medical clinic in our syringe exchange program. We decided to try to make this available to people upon their enrollment. So because the induction requires withdrawal, our experience was very unlikely that people will voluntarily force themselves into withdrawal. What we did know is when people come for exchanging syringes, many happen to be in withdrawal when they were requesting syringes. So this was a very unique opportunity to ask people if they would be interested in a tablet. So upon enrollment or presenting for exchanging, we would ask injectors, would you like a syringe or a tablet? If they said, okay, we would tell them in 20 minutes or so you would feel fine and not need to inject all day. They would see our physician. Upon successfully completing the assessment, they were given a tablet and feel better and hang out all day in our drop-in center or do whatever they wanted to do. Okay. So we also told them, if you like, come back the next day and we would give you another tablet. After a week of coming every day or several times, we would then inquire if they would be interested in a 1-week prescription, or 1 week's worth of medication. During that week, we would ask them to come in twice, once in the middle of the week for a checkup, and at the end for an assessment to see if they were interested in continued treatment. At this time, it was in 2004, the New York City Department of Health was really promoting buprenorphine. And needle exchange programs who were connected to medical services or had an available doctor were starting to do this as well, but as a treatment option, not necessarily as an HIV prevention option. So many programs were starting to seek medical care. There were 2 other programs in New York that had medical services available by working with nearby hospitals. The Harm Reduction Coalition in the United States actually launched a BUP study with a physician that would, So this is the study that a friend and colleague of mine, Dr. Sharon Stankliff, did. This woman, doctor, she would go to 5 programs during the week, 1 each day, and prescribe buprenorphine to people who were eligible. And the outcomes were very comparable with patients who were being seen in office or clinic settings. So, what are the lessons learned? Well, despite the unique design of this intervention, very few participated. 85–90% of our participants were already enrolled in methadone, creating barriers. Many who are experiencing withdrawal also misuse benzodiazepines, excluding them from access to buprenorphine. And you have to remember, buprenorphine just became available. There were very few physicians available who would prescribe this. People were very reluctant at this time to just prescribe. So people were being very strict to the new federal guidelines. And yeah, that's about it. So what the study shows is that despite the fact that we were located between 2 methadone programs, our participants were primarily enrolled in methadone at high levels. The programs were not really interested in reducing their dose to switch them. That in other settings where needle exchange program participants were not enrolled in methadone, that they were recruited successfully into buprenorphine. So this study and this intervention is successful. It can be successful for people who are not who are methadone treatment naive, so to speak. So thank you very much, and thank you.